One of the tallest hurdles in overcoming health inequity in our country is structural racism and implicit bias. Black patients encounter racism at every point of engagement in our healthcare system. During scheduling, checking in, during the appointment, fighting to be heard, when leaving, during payment, rescheduling, referral, and follow-up. We also know that this is an issue ingrained in the very training of physicians in our country. This is a very popular study that demonstrated that medical students and residents already arrive with fixed false beliefs about the physiological differences between blacks and whites, such as they believe that black patients have deeper nerve endings, or their skin is thicker, or their blood coagulates differently. This spills over into our formulas that we use to determine when a patient would benefit from intervention, such as in renal disease or pulmonary disease. Medical equipment algorithms and AI are created by people in the absence of diverse thought, and as a result can leave black and brown patients on the periphery with equipment that overestimates their blood oxygen saturation, for instance, or doesn't consider their risk position in tracking follow-up. During training, the textbooks provide instruction with medical curricula that was created with theories about biological inferiority of people of color. Currently, studies demonstrate that our board question vignettes, therefore all the preparation that goes into these high-stakes exams, are racist. So what is the solution? The solution is to create a diverse physician workforce. This means make more black doctors. There is currently a deficit of black and Hispanic doctors when you consider our proportion of the American population. In 2015, we were down about 81,000 black doctors. It would take 66 years of sustained doubling of black medical students to correct this deficit. This graph, you can see that in 2010, Asians were overrepresented. Whites were just about right. The rest were underrepresented. By 2015, Asians are markedly overrepresented. But you can see all the rest are worse off, with people of color faring the worst. It is the charge of American medical schools to create the doctors that the American population needs. In a diverse American population, we need diverse American doctors. Let's talk about this study that shows that black people who live in counties with more black doctors, whether they see the doctor or not, resulted in lower all-cause mortality for all people, not just the black people. Let's think of it a different way. Let's say there is an overpass and there is no barrier. So certain people will fall off. Maybe people who are new drivers, people who are young, people who drive certain types of automobiles, or they drive at a certain time of day or night or in certain weather conditions. They fall off the side. So now there's outcry. People who drive at night are falling off the overpass. You have another group of people saying, well, it doesn't affect me. I'm not falling off the barricade. Maybe those people should just not drive at night. Argument on the other side is, but there are people who need to be in places to keep society working that have to be in transit at night. Building a barricade not only helps the people who work at night not fall off the freeway, right? It helps all people. It makes all people safer. The mechanisms that we put in place for health safety and health surveillance benefit all people. Yes, it benefits marginalized people, but in so doing, it also benefits everybody, because that barricade, that railing helps keep all drivers safe. The mechanisms that support and demand excellence in healthcare delivery will help all patients. It's amazing to me that this point is not obvious to everybody. So back to this study. Every 10% increase in black primary care physicians was associated with a 1.2% lower disparity between blacks and whites and a lower all-cause mortality. Then there are the babies. In this study, there is a 56% mortality penalty of just being black as a baby when treated by white doctors. Newborn physician race concordance is associated with significant improvement in mortality of black infants. So what does this all mean? It means that we need more black doctors. And the creation of a doctor does not start in college. The creation of a doctor begins in grade school. We have to invest in children in grade school so that they are ready for pre-AP. They are available and ready to take the AP classes. Whether or not they use AP credit, they are at an academic level where they can perform so that when they get to college, they are competitive. We need support services in place for families. We need support services in place, tutoring, interventions early. By the time the child gets into high school and college, it is too late. If we are serious about making freeways safer for all drivers by building guardrails, then we should also be able to see that we can make healthcare safer, healthcare better for all people by building guardrails. Guardrails includes a diverse physician workforce because everybody wins.